Today, let's talk about pitfalls in pathologic diagnosis. Working as a pathologist is both challenging and rewarding, but our work is full of potential traps. Stepping into any one of these pitfalls can lead to misdiagnosis and, ultimately, serious consequences for patients. The goal of this video series is to help us stay alert, avoid common pitfalls, and keep patients safe. This case involves a 62-year-old male who presented with enlarged neck lymph nodes. A prior biopsy, performed at an outside hospital, was diagnosed as granulomatous inflammation. Unfortunately, those slides were not available for review. The patient was treated with antibiotics and steroids, but his lymph nodes continued to enlarge, prompting a repeat biopsy. On the core biopsy, the normal lymph node architecture was completely effaced. We observed the irregular sheets and small nests of abnormal cells with abundant fibrosis. At higher magnification, the tumor cells appeared monotonous, with prominent nucleoli and a moderate amount of pink cytoplasm. There were numerous mitotic figures and apoptotic bodies, indicating a high-grade malignant neoplasm. In other areas, tumor cells formed linear and small clusters separated by fibrosis, with small lymphocytes intermixed. Morphologically, this was a difficult case. There were few definitive clues. The differential diagnosis included carcinoma, sarcoma, lymphoma, melanoma. Immunohistochemical stains were performed to help narrow the differential. This picture shows positive AE13 staining. We see perinuclear positivity with AE13. CAM5.2 is also positive, showed a similar perinuclear staining pattern. The tumor cells are negative for CK7 and CK20. Transcription factors including TTF1, CDX2, PAX8 and NKX3.1 were negative. Squamous cell markers, lymphoma markers, sarcoma markers and melanoma markers are all negative. Based on these findings, the tumor was diagnosed as poorly differentiated carcinoma, not otherwise specified. Following this diagnosis, the patient underwent a clinical workup for carcinoma of unknown primary. Imaging studies revealed diffuse lymphadenopathy, involving the neck, axillary, para-aortic, and pelvic lymph nodes, but no primary mass lesion was identified. In addition, serum LDH was markedly elevated. Given these findings, the oncologist questioned the diagnosis of carcinoma. He suspected lymphoma, with the elevated LDH suggesting tumor lysis syndrome. The patient was admitted for management of tumor lysis syndrome, and a resection of an axillary lymph node was performed for further evaluation. On the resected lymph node, we observed sheets of tumor cells separated by incomplete fibrous septa, with small lymphocytes present within the fibrous bands. In this picture, we can better appreciate tumor cells with incomplete septa, as well as small lymphocytes inside the septa. At high power, the tumor cells were uniform, with prominent nucleoli and moderate clear cytoplasm, giving a classic fried egg appearance. So what's the diagnosis based on morphology? This is seminoma, with textbook characteristic morphology. The final diagnosis was metastatic seminoma. We misdiagnosed it as poorly differentiated carcinoma on the neck lymph node biopsy. Subsequent testicular ultrasound revealed multiple small bilateral lesions, largest 8 mm. Serum beta-HCG was mildly elevated, consistent with seminoma. The patient was treated accordingly and showed an excellent clinical response. The neck lymph node decreased from 15 cm to 6 cm after therapy. Retrospective staining of the original neck lymph node biopsy confirmed the diagnosis. Here we can see that the tumor cells are diffusely positive for OCT34, also diffusely positive for SAL4. CD117 is also positive. This confirmed that the tumor was indeed metastatic seminoma, not carcinoma. So, what can we learn from this case? Stay alert to morphologic clues, especially when encountering rare entities, or common entities in uncommon sites. In this case, seminoma, a common tumor in the testis, presented in an unusual location, neck lymph node. Secondly, it is essential that we need to correlate morphology with immunohistochemistry. In the initial biopsy, the cytocarotid paranuclear staining suggested scant cytoplasm, which did not match the moderate cytoplasm seen on H&E. This mismatch was a red flag for nonspecific staining. Immunostains are powerful tools, but diagnosis must always correlate with morphology. To wrap up, to avoid pitfalls like the case we just discussed, we need to be alert to morphologic clues of either rare entity or common entity at uncommon anatomic site. Second, we should avoid making diagnosis solely on immunohistochemical results. Correlation with morphologic finding is essential to avoid misdiagnosis.